Good morning, everyone, and welcome to today's webinar titled Introducing the Behavioral Health Cessation Coordination Model. Thank you for joining us today. This is the second webinar in our spring series, a three-part series that the Behavioral Health and Wellness Program is offering through its Whole Health Innovation in a Time of Uncertainty project. And I'll tell you a little bit more about that project in just a moment here. My name is Derek Noland. I'm a community liaison here at BHWP, and I'm very happy to be joined today by my colleague, Jim Pavlik, who is the Senior Program and Policy Analyst at BHWP. I'll be introducing the Whole Health Innovation Project in today's webinar at the beginning of this presentation, and then I'll be turning it over to Jim to lead us through the Behavioral Health Cessation Coordination Model in much more detail. I'll then conclude the webinar today with a brief overcap and an overview of what we've covered, just to put it in very simple, clear terms. And we'll have a few minutes for questions at the end of the presentation as well before we conclude for the day. So again, this is the second webinar in our three-part series under the Whole Health Innovation Project. And this webinar aims to follow up on the webinar that we offered last month, which perhaps some of you attended, while also introducing our behavioral health cessation coordination model today. So in summary, here's what we'll be covering today. We will examine the structure of the behavioral health cessation coordination model. So we'll look at all the different components within it. We'll look at the different categories that we've identified. And really kind of the nuts and bolts of what the model entails. We'll describe the key types of behavioral health services that are included in the behavioral health cessation coordination model. So we will take some time to look at what those health services are and to try to think about them within the context of the model. And finally, we also hope to explain the utility and the applicability of the behavioral health cessation coordination model. So we intend to leave you with some understanding of why we've developed this model and just how we think it can be useful to the community here in Colorado. And ultimately, we do hope that this tool will help agencies to be able to help their clients to best engage with the Colorado behavioral health care system. So for a bit more background about the project at large, the Whole Health Innovation in a Time of Uncertainty project aims to assist behavioral health agencies around the state of Colorado to implement different types of self-directed goals related to services regarding tobacco dependence treatment, tobacco policies, things of that nature. It does allow agencies to identify areas in which they want to focus within this framework. And so each year we do work with several agencies around the state in order to help them to accomplish and fulfill goals that they identified in this spectrum. So we do welcome if there are agencies interested in participating in this project next year or in future years. We do have openings available and we welcome those opportunities. In addition to working with agencies through the project, another thing that we do is we develop tools that can be used by the public, not just participating agencies, but by the public at large. And that's really what the behavioral health cessation coordination model stemmed from, is from this initiative as well. So this model will be available for public use. We will host it on our Behavioral Health and Wellness Program website, which is www.bhwellness.org. We have many free tools available at that website, and this model will be included among those very shortly. As an additional step in this long-term project that we have aiming at increasing the rates of tobacco cessation across the state and decreasing tobacco use at large, next year, we'll be creating a toolkit that will help to instruct agencies on how to most effectively use the behavioral health cessation coordination model. So because the Colorado behavioral health system is so complex and because the model does require a bit of understanding and a bit of direction, we envision this toolkit as being a really useful supplement to help agencies to maximize the potential of the BHCCM to be able to really help engage and route clients accordingly, and to develop systems that work within the framework here in Colorado. In addition, we also offer webinars, which is what you're participating in here today. So to recap the webinar series this spring, again, this is the second one in this three-part series. Our first one was titled Understanding the Colorado Behavioral Health System. This talk was led by Dr. Charles Smith of SAMHSA, and we will be tying back to that webinar as we go through today. This webinar is already hosted on the Behavioral Health and Wellness Program's YouTube channel. So if you have not seen this webinar, we invite you to take a look at that. It would help provide some context for today's webinar. And then the third webinar in our spring series will be titled Engaging the Colorado Behavioral Health System, Routing Individuals to Tobacco Treatment. And Jim and I will be leading this webinar again. And in this webinar, we really aim to offer some case studies, some examples that we can use to walk through the BHCCM and understand how it can be valuable in routing and directing clients. So more to come on that webinar, but you can see there it'll be, again, Tuesday morning at 10 o'clock on June 7th. Okay, and finally, before turning it over to Jim to cover the model, I do want to underline that BHWP operates under the following wellness philosophy, and that is we want people leading a meaningful and fulfilling life through conscious and self-directed behaviors, focus upon living at one's fullest potential. And so today we are focusing on empowering agencies to support clients in this respect by enabling them to best understand the Colorado behavioral health system and therefore to route people to optimal care. As Jim will discuss during his part of the presentation, people with behavioral health conditions in Colorado, they do want to quit smoking. They try to quit smoking regularly every year, and many of them can succeed in this pursuit, particularly if they're provided best practice supports and counseling and medication and other things that may be useful in that regard. And so with that, I'll now turn it over to Jim to take us through the behavioral health cessation coordination model in more detail.
Great, thank you. Thank you, Derek, and good morning to all of you. Thanks again for joining us today. I'm very excited to introduce our model for simplifying engagement with the extremely complex and intimidating public behavioral healthcare system. But before getting into the model itself, I do want to do a couple things first. First, I want to very briefly define who we are talking about and make the case that doing this is both the right thing to do and also a worthwhile enterprise. And then right before introducing our model and walking through it, I want to provide some brief introductory remarks on models in general and how they are best used. If you were in attendance during the first webinar, you know that the behavioral health system in Colorado, despite an earnest decade-long effort to simplify it, remains Byzantine. There are multiple funding streams going into multiple agencies, all with slightly different missions. And simply put, the behavioral health system is the behavioral health system. To simplify it at all is to risk oversimplifying it. I just want to make sure that we use our model for what it's good for and not look to it for an order or a logic that simply just doesn't exist. And then finally, I'll present the model itself before turning it back over to Derek. As we go through the presentation today, I want you to try your best to hold 5 things in your mind. And these 5 facts govern in varying degrees everything that we're going to be talking about today. First, we need to understand that nicotine dependence is an extremely common co-diagnosis across mental illnesses and use disorders of other drugs. Despite, maybe even because of this level of dependence, individuals receiving services for other mental illnesses and substance use disorders want access to nicotine recovery services. Because they want such services and because such services can deliver improved health and improved quality of life, as public health employees, as behavioral health professionals, as policymakers, as good friends and family members, and as good neighbors, we have an ethical obligation to make sure that individuals who want these services have access to them. And finally, we need to understand that nicotine dependence is not some ignorable or exaggerated myth. Nicotine is more addictive than any other drug of abuse. And while every drug dependence is unique, all dependencies fundamentally share one trait in common, and that is that they impact the brain in such a way as to simultaneously and distinctly encourage future drug use while depressing the ability to choose not to engage in future drug use. Dependence is a doom loop, trapping individuals in a cycle of use, withdrawal, drug seeking, and use. It's not impossible to overcome this damage and escape the doom loop. However, nicotine is unique in a lot of ways, and one of them is that individuals are unlikely to simply quit on their own. Nicotine recovery requires access to and use of evidence-based treatment, not educational brochures, not squeeze balls and mints. Our gold standard of care for nicotine dependence is medication-assisted treatment plus counseling. This combination of those two things increases the odds of success 600%, from 5% without assistance to 30% with it. So I want to spend just a second really narrowing our focus on that first bullet point on this slide. To reiterate, we are not talking about tobacco use. We are talking about treating nicotine dependence. And nicotine dependence, even in the general population, is quite high. By the most conservative estimate, about 50% of tobacco users would qualify for an official diagnosis using DSM-3 criteria, which is, of course, 2 DSMs ago. Depending on how you measure dependence, it can actually go quite a bit higher. We know that historically about 70% of current smokers want to quit, and that 55% of smokers will try at least once in any given 12-month period, and most of those will not be successful. The American Academy of Addiction Psychiatrists and the author of the book Golden Holocaust both put that number somewhere between 60 and 80% who would qualify for dependence. Over 80% of smokers express discontent at their inability to quit, and that discontent is frequently accompanied by reports of lower health or fear of contracting a tobacco-related disease. And experiencing regret of having started the habit is nearly universal, with 90% of current smokers reporting regret. Researchers have discovered that whatever the dependence rate is in one population of users, it is often higher in populations where the baseline prevalence rate is higher. And therefore, while the percent of individuals who are dependent on tobacco in the general population could be as high as 90%, depending on what your criteria is for dependence, it could be, and almost certainly is higher than that among the behavioral health population, where prevalence rates differ by condition, but tend to be 2 to 3 times higher than the general population prevalence rate. I use this graph here to suggest that our policies have, in fact, left behavioral health populations backward in time. You can see here that while only 13.7% of adults in the general population smoke, between 32 and 62% of individuals with anxiety smoke, effectively leaving them in 1981. Between 34% and 80% of individuals suffering from alcohol use disorder also smoke, leaving them in 1979. And there are comparable figures there for depression, ADHD, PTSD, other drugs of abuse, bipolar disorder, and schizophrenia. While it might already be clear from this chart who we're talking about when we say the behavioral health population, just to make it explicit, we are fundamentally talking about 2 broad sets of groups. Those are those with mental illnesses and those with substance use disorders. That's who we mean by the behavioral health population. By mental illnesses, we really mean dysfunction in 3 broad areas: stress, mood, and psychotic disorders. And we need to understand that the relationship between each of these domains and tobacco use are bidirectional. And what that means is that, that tobacco causes, for example, mood disorders, and untreated mood disorders may encourage people to self-medicate with nicotine. But it's also the case that both tobacco use and mood disorders are both more probable if the individual is exposed to certain risk factors, especially during childhood. And I do want you to focus on that red dot as I advance the slide. Here again, we see that although this slide is less complicated than the previous one, we can still see the presence of that same triangular causal relationship. Drugs of abuse prime the brain for addictions to other drugs. So while this presentation focuses on the relationship between tobacco use as a cause of and a result of addictions to opioids, cocaine, methamphetamines, etc., we could easily have drawn an arrow from any specific other drug of abuse to any of the other drugs. Many individuals with a diagnosed substance use disorder either use multiple drugs or easily transfer their use to other drugs should they find themselves in a situation where their drug of choice is unavailable. And once again, we do see that both tobacco use and the use of other drugs are both associated, again, with that red bubble on the bottom, which has now been drawn out on this slide. There are several features, especially about treatment settings and the educational background of treatment professionals, that unite mental illness treatment and substance use disorder treatment. But another thing the two populations have in common is a shared set of known risk factors that contribute to both addiction and poor mental health. We won't be dwelling on the pathology of these two conditions in today's webinar, but I felt it was important to acknowledge why we tend to talk about these two groups together, despite the wide variety of conditions within each of these two groups. Given that the two groups often share common risk factors contributing to the development of their addiction, it won't surprise you to learn that individuals suffering from either are relatively likely to suffer from the other. In 2020, the National Survey of Drug Use and Health estimated that about 21 million adults had an SUD. That works out to about 10% of the adult population, and 36 million adults had a mental illness, and that's about 17.2% of the population, so 10 and 17% respectively. By contrast, the number that had both was 17 million, which works out to 47.4% of individuals with a mental illness also having a substance use disorder, and 81.3% of those who had a substance use disorder having a comorbid mental illness. So as we move into the next section, I want to leave you with two final facts. Tobacco use, along with other drugs of abuse and or along with mental illness, is extremely common, but individuals suffering from these conditions want to quit. In fact, they want to quit at higher rates than the quote unquote general population. You can see here the rates among the general population in black and gray there to the left, and then along the in the green and orange, you see general psychiatric outpatients, depressed outpatients, psychiatric inpatients, and methadone clients. So a sort of a wide variety from the spectrum of the behavioral health population. And you see that across the board, that the numbers who want to quit within the next 6 months or in the next 30 days all outnumber the numbers of those same figures in the general population. And then the second final fact is, in addition to wanting to quit, and this is like sort of our word of hope, and actually the reason that all the things I just mentioned rise to the level of a moral imperative, it's not just that individuals want to quit, it's also that they can quit. And with the proper support, their chances of success mirrors, and in some cases surpasses, the same chances of individuals in the general population. However, without access to evidence-based support, their chances drop precipitously, which is why your interest in this topic and your attendance today is so important. So very briefly, I want to offer some opening remarks on what models are and what they're good for, so that we don't ask too much of our model or attempt to use it for tasks for which it was not designed. It's easiest to start with what a model is not. A model is not a picture of a complex system with lines and boxes or concentric circles or stacked triangles or anything else like that. I didn't design a fancy graphic for our model. Many models are presented graphically, and I do think there is a soundness to the logic that anything simplified enough should be able to be presented graphically, although I do rush to add that I've seen visual representation of systems like the one pictured here of our metabolic systems that are eye-strainingly difficult themselves to comprehend. It just so happens that in this particular case, the system it represents is even more complex than the complex graphic that it quote unquote reduces down to. Rather than a graphic, a model is simply a way of thinking about something. Models tend to be reductionist in nature. They try to eliminate noise and complications and variation, and in some cases try to present the thing in its most ideal or representative form. When you see a picture of a skeleton in an anatomy book, that is a model of a skeleton in the sense that it's going to remove the asymmetries that appear in an actual person's skeleton. Small fissures or protuberances that are ubiquitous and important, but hard to spot in a real skeleton, will be artificially made more pronounced. Another type of model, and one more similar to the one I'm about to present, is a taxonomy. Breaking the animal kingdom down into fish, amphibians, reptiles, birds, mammals, all the rest. That's artificial. Nature knows no such boundaries. And such boundaries, when we confuse the taxonomy for the things it's meant to impose an order upon, can lead us astray. The platypus is real and does not care about the commonalities between mammals and birds, which it openly defies. It is our hope that our model may be meaningful and therefore useful, even if it is ultimately wrong. So one of the things before going into ours specifically, we should know that there are lots of models out there of the behavioral healthcare system, or as it's pictured on this slide, a break between the mental health system on the left, bottom left there, and then the substance abuse treatment on the bottom right. And depending on what you're trying to use the model for, it changes whether or not it's useful or not. So this one is trying to identify gaps in a supposed continuum of care, whereas this one on the left here is really kind of talking about intensity of care and the differences of care provision at those different intensity levels. You see some that emphasize timing, those sorts of things. Our model was inspired by the one on the bottom right, which again, if you were in attendance during this first webinar, you've seen these last two slides that I've just shown. This model is called the sequential INTERCEPT model, and I find this model to be extremely useful. I used it to design tobacco cessation programs for criminal justice system involved populations, and I have used it to offer what I hope is good technical assistance for others hoping to design tobacco cessation interventions for those populations. It's not a perfect representation of the criminal justice system. A lot more people are arrested or detained than those who spend any significant time in jail, and a lot more people end up in jail than go to prisons. But the model is flat and unidimensional, and this singular dimensionality implies an inevitability of the process. Those who go in through the door on the left wind their way through the system from INTERCEPT 0 to INTERCEPT 5, but of course, and then wind up back out in the community. But of course, this is not an accurate reflection of what really happens, although it does depict the path that some people do take. Our model is very similar to this one in that way. There are a lot of reasons why one may need to access the behavioral health system. And there are many doorways into it, and many things will determine how one passes through it and which of the institutions one will experience along the way. There is no straightforward linear progression through this system. Rather than think of our model as how one gets to these various locations, I'd like you to think about the locations, locations themselves. And specifically, I want you to think about the following attributes of those site locations. How long is the tobacco user in that space? What professionals are in that space with them? What type of access does that person have to the outside world, and or what type of access does the outside world have to that person inside? And what is the general skill set of the professionals that the tobacco user has access to while they're there? And we can actually reduce this even a little bit further. What services does the tobacco user have in the behavioral healthcare site that resemble or can be aligned with the evidence-based standard of care to treat nicotine dependence? Now, to fully answer that question, we have to have a decent understanding of what the standard of care is, and BHWP thinks of this as a two-part answer. On the one hand, we have the evidence-based treatments pictured on this slide. These are the services that are given a grade of A by the United States Preventive Services Task Force. That is the things in the green bullets to the left, not the lowercase, the box in the lower right-hand side there. We can think of all of these treatments as having a frequency, intensity, and a duration dimension. And any one of those three knobs can be turned up as the tobacco user's needs go up. So what would help us make the determination whether this or that knob needs to get turned up? Well, there are three main factors. The level of dependence the tobacco user has, and we want to measure that in a standardized way using a validated instrument. The risk factors the tobacco user is currently experiencing, like higher poverty, less access to regular care, no insurance, criminal justice system involvement, lower income or no job, etc. These are things that increase the stress a person is likely to experience while removing their access to non-nicotine coping strategies. And then the final factor here is the tobacco user's own preferences. The only time that we can get too intense is if we force a tobacco user into a treatment environment that surpasses their willingness to endure it. If a patient wants a 30-day inpatient setting with daily tobacco cessation classes and medication to address their issue, there's no medical or philosophical reason to oppose that choice. Now, there may be social or familial or occupational or financial reasons why we wouldn't want to go that route, but from a purely cessation-driven perspective, we can put that option on the table without any issues. So what is the tool or what is the process we use to determine which evidence-based treatments and at what intensity the tobacco user should have access to? And the answer to that question is we use the 5 A's. So for those who don't know, the 5 A's is an evidence-based protocol for addressing chronic diseases or encouraging healthy behaviors in a preventative way. It was specifically designed by primary care physicians to be used during a routine medical encounter in a PCP's office and to address tobacco use in particular. But it has since been shown to be effective across a variety of conditions, including diabetes management or heart health, and in a number of care settings, including dental offices, community behavioral health, pharmacies, and others. The 5 A's stands for what's in the bubbles here: ask, advise, assess, assist, and arrange. And these 5 functions give a starting point for aligning the services available inside the behavioral health system with those services needed to appropriately address nicotine dependence. Once we understand the functions of the 5 A's, now we can look into the behavioral health system sites to see which and how many of the 5 A's are being performed there by the professionals residing in that space. And that gives us the taxonomy of sites that we used to construct our model. So fundamentally, just to recap this section, we are using the 5 A's to direct people to the evidence-based cessation interventions. As we move into describing our model, I want to start, there we go. As we move into describing the model, I'm going to start with and quickly dismiss 2 categories of spaces where we might still find tobacco users and extend to them evidence-based services, but I want to kind of deal with them very quickly for reasons I'll explain as we go through here. And those 2 categories are the community itself and also situations where law enforcement may be involved or is likely involved, is on average involved, that sort of thing. So I'll describe what I mean as we go through it. So the first of these is the community itself, the neighborhoods, workplaces, parks, even homes of our tobacco using target. The fact is that most individuals who might be suffering from a mental disorder or developing or suffering from a substance use disorder aren't actually receiving care for it, right? They're just going through their regular day, and there's a lot of reasons why that may be the case. And while BHCCM does recommend prioritizing this group for our tobacco control, prevention, and cessation efforts, the model we are presenting today isn't just about addressing the tobacco cessation needs of anybody with a behavioral health issue. Our model is about figuring out ways to collaborate with the system, with the behavioral healthcare system. As such, even though the vast percentage of behavioral health patterns are encouraged and established through factors experienced well before and outside the behavioral health system itself, we nevertheless consider this to be category 0 for purposes of the model. This is an important place where our target audience exists, but by virtue of their current lack of contact with the system are outside the parameters of our system-based model. The second area I want to deal with quickly are encounters with public safety personnel and or with mobile crisis response units. And there's a lot of models of these services. Some only use social workers or other behavioral health tech respondents. Others use law enforcement officers who have received extra training on behavioral health related matters, and often specialized de-escalation techniques suitable for individuals in the midst of an acute behavioral health episode. And some use collaborative teams, on and on and on. There's a long-standing recognition that jails have become de facto behavioral health treatment sites, which is to say that many individuals who are in need of behavioral health treatment find themselves instead in jails. And many crisis response units of the type I'm sort of referencing here serve to reduce the amount of people who need to enter the system at all. And then if people do need to enter the system, they try to redirect them away from a criminal or a public safety based site and into relevant and actual therapeutic behavioral healthcare sites. But in any case, we should assume 2 things about these particular types of encounters. At the moment that the crisis response unit responds, whether or not that individual uses tobacco is just simply not an issue that rises to any level of importance. Even if it were the case that the episode that they are currently involved in was somehow triggered or exacerbated by tobacco use or withdrawal, the response unit has to deal first and really exclusively with the incident that precipitated the arrival and stabilizing that individual. The second assumption is that this person who has had crisis response unit called on them, this person is either going to return home and therefore to category 0, or they're going to be transferred to either a behavioral healthcare site or a public safety detention facility, aka a jail, which is to say that we are going to have a chance to work with this client or patient once they enter that system, if that is in fact where they go. So I do want to add that engagement at this level, at the crisis response level, it's not impossible. And it's not philosophically inappropriate. As we'll see in just a minute, it's not at all inappropriate to begin treating nicotine dependence proactively at other points of care where the individual of concern are still in crisis. We do consider this category 1 and not a part of category 0 after all, right? It's sort of that liminal space between the two systems, or the at-home community-based system and the actual behavioral health system proper, but it's not, we're considering it like more to the right, more toward the system. While there are many reasons we don't consider this an optimal engagement point, one important limitation we do have to consider here is that the mission of the crisis response unit is to de-escalate the crisis. Of our 7 FDA-approved pharmacotherapies, none of them are going to have a crisis response time to action. That is, drugs like bupropion and varenicline need several doses and days of use to build up in the system to create their therapeutic effect. And even if we determined, and by the way, this is unlikely if not impossible, but even if we determined that the cause of the episode was nicotine withdrawal, so relief of withdrawal symptoms would medically resolve the crisis, we would still have a timing problem. The patch takes 2 hours to peak in the blood, and the gum and lozenge both take 30 minutes or so. The most fast-acting nicotine replacement therapy is the nasal spray, and it still takes 10 minutes to deliver its effect. And the timing issue is then stacked on top of the near impossibility of being able to forcibly administer them, unlike other drugs that are sometimes deployed in crisis situations like naloxone. Category 2 sites are those areas where people arrive to the behavioral health system in an acute state of distress. And these may be detoxification sites, emergency departments at hospitals, walk-in or crisis centers, that kind of thing. Like the mobile crisis response units, the immediate aim of these sites is to stabilize the patient's condition and then typically transfer them to a less restrictive care site, which may in fact be their home, or it may be there on site. Patients may arrive at such sites under the effects of a drug or extremely agitated or in the grips of a psychotic episode, regardless if the person is brought in conscious or unconscious by law enforcement or hospital staff, by family members, or under their own recognizance. The patient is normally going to be immediately assessed for their symptoms and the possible causes of those symptoms. They will then be triaged to care, and some care will be provided in that space, right, at that location, which is to say on site. These spaces, at least in Colorado and in most other states, are subject to Clean Indoor Air Act laws and are therefore smoke-free inside, which I only bring up very quickly and sort of as a tangent. I only bring it up to suggest that in addition to any cessation interventions delivered by the staff or the patient, working with the behavioral health system may mean designing nicotine-free organizational policies and staff support programs. And that's actually going to be true of all of the categories that we're talking about. Because these sites are already screening for exposure to drugs, recent and chronic, and because we have already trained specialists on site who are doing that initial investigative work looking for drug interactions, these sites can easily screen for nicotine use. In fact, there are several common validated screening instruments that already have tobacco products included. Emergency departments and urgent care sites are a pretty good model of what the behavioral health system should be doing here, or could be doing. And just like the sites that we're talking about in the BH system, emergency departments are often dealing with patients who come in dealing with extreme physical distress, unrelated to nicotine, and maybe even unconscious. But many EDs have no problem providing their tobacco-using clients with a nicotine patch or some other nicotine replacement therapy, either by request or immediately upon a positive screen for smoking. Such proactive care can greatly reduce stress in the patient and reduce the discomforts related to withdrawal, and it can encourage compliance with tobacco-free grounds policies. And moreover, in a situation where doctors need to stabilize medications rapidly, it's really helpful to have patients who are not cycling up and down on toxins, which make maintaining proper dosing levels difficult. We know that tobacco smoke in particular, not the nicotine, can impact the effectiveness of varying drugs, including some antidepressants, antipsychotics, etc. So our behavioral health care sites should be following the lead of our hospitals here and providing nicotine replacement therapy to those clients identified as smokers. And it's here that I want to mention that these sites may have an agreement in place with a mobile crisis unit or with their local sheriff's department or some other transportation source, which is to say, since we know that we want to stabilize the client when they, by the time they get here, we can actually start fast-acting nicotine replacement therapy while the person is en route. Once that they determine that they're going to need care at a behavioral health site, as the sheriff's department, as the mobile crisis unit is transporting that individual, they can actually give them nicotine replacement therapy while they're on their way, so that we're already treating those withdrawal symptoms before that client starts to enter that intake process. And we should also know very quickly, and I'll return to this topic again, that these sites often serve as way stations to other points of care. And 5 common pathways out of these sites are back home, to a community behavioral health organization for ongoing outpatient care, or to residential substance abuse treatment, to an inpatient psychiatric facility, or even to jail. Now, I'm going to move on to category 3. So you're going to notice, especially once I advance the slide, that a lot of our category 3 sites are also category 4 sites. There's just a lot of overlap here, and I'll talk about that as I go through here. These are facilities like substance abuse centers that have both outpatient services like support groups and also inpatient or residential programs. Or they could be hospitals that provide inpatient and outpatient psychiatric services, or even community mental health centers that may operate group homes, transitional housing, assisted living, and also outpatient services. So once again, in order to build your collaborative partnership with these organizations, you may approach them thinking to develop service provision for outpatient communities or for inpatient ones, which is to say that basically any outpatient site is a category 3 site, and those inpatient or residential facilities are going to be our category 4 sites. The key difference between category 3 and 4 is the restrictiveness of the conditions which would require different treatment or care approaches. Outpatient facilities may have to work harder to educate their clients on the proper use of NRT. They may have to help facilities they may have to help connect the patient to transportation, to their coaching, counseling, or group sessions. They may have to do more follow-up with the patient to make sure they are following through with the services. Outpatient care may involve the provision of wraparound services, including in-home services, respite services, which involves multiple support staff, and all of them are going to need to be educated and trained on supporting that tobacco cessation effort. By contrast, things like medication management and group attendance and abstinence are actually much more easily mandated or otherwise controlled within the residential settings. Certainly, severe restrictions do open up the opportunity of black markets and covert use, especially in large facilities with lots of nooks and crannies, and when the residents have a lot of unstructured time. There are trade-offs, right, in residential facilities, and this, by the way, it does include jails and prisons, in addition to more formal behavioral health organizations like the ones I've already been mentioning. The trade-off here is that while it is easier to force clients to maintain abstinence and partake of various treatment options, it is much harder to measure and activate motivation. It is much harder to process with a client their feelings around abstinence and the potential grief involved. And it's virtually impossible to work with a client after a triggering episode or an actual lapse in abstinence. And these are circumstances that present themselves already in the real world, or in the outside world, or in the outpatient population, but not so much so in the artificial world inside that restrictive treatment setting. So we had considered labeling these two entities the same, like maybe category 3A and category 3B, not just because they're so frequently the same spaces, but because in terms of having skilled staff already performing all 5 of the 5As, or easily aligned with similar tasks, they're basically identical. Inpatient or outpatient facilities, mental health, substance use, criminal justice, they all have personnel who collect information. And this information includes basic demographics, of course, but also typically a wide data set of various mental health functioning, drug use, including screening for various drugs, their recency of use, their frequency of use, their onset of use, and sometimes other factors like previous recovery attempts and involvement with law enforcement. They all have a process by which the person's various needs, including their mental health and medical needs, are identified. Even in jails and prisons, either or both of these things are assessed in order to make sure that inmates' medications are being properly administered for the inmate's safety, as well as for the safety of other inmates and the correction staff. In some cases, the jails and prisons are large enough that they actually have on-site health divisions to service inmates' needs. These individuals are more than equipped to assess nicotine dependence and to make a medication recommendation or provide a prescription if warranted. They can also oversee the use of those medications, design an ethical titration schedule, and generally oversee the entire withdrawal schedule. These sites, at least the community behavioral health sites, are already equipped with staff trained in facilitating behavior change. which is to say all the aspects of educating, coaching, and counseling. They may already have a logistical or operational infrastructure in place for running psychoeducational groups. Such sites sometimes need extra training in nicotine dependence in particular, but nowadays many personnel are certified addictions counselors with at least some knowledge of nicotine's unique characteristics. And in many cases, they may already even have a certified tobacco treatment specialist on staff. Finally, these sites already have a process in place to arrange for future appointments, to refer to other care providers or other service provision entities. They often have transition staff in place, specifically to handle continuity of care concerns between such providers. Which is all to say that simply in terms of the ability to perform the 5 A's, these spaces can do it all. They may not know that they can do it all, and that may require targeted education. They may not think they can do it all, and that's just really confidence building. And they may not already know that they are, in fact, actually already doing it all, but typically these skills do reside within these particular walls. The potential exception here are jails and prisons, which may or may not have their own staff doing things like providing education, providing counseling, or running groups. However, in those instances, you will typically find that they outsource or contract for those services. But that's also the case for some community behavioral healthcare organizations in the context of some of their more niche offerings. So that process of outsourcing may also already be a skill set that's in place. What led us ultimately to make the decision to separate these out as 2 separate categories are the differences between the patient sets and the resulting differences in what the program may look like in those 2 spaces. Remember, our categories are based both off site and patient characteristics, including their length of involvement with each point of care. Outpatient services can be court ordered and therefore time limited, like a sentence is time limited. They can also be made available for as long as a condition warrants professional attention. In the cases I'm thinking about, we normally are talking about an intensity level condition that might end the service if the client rises above a certain threshold of functioning. Such terms are normally dictated by the service payer, the insurance company. Or such services may run indefinitely as long as the client continues to want those services. All of these service levels also exist in the inpatient spaces, but there's less variation for a variety of reasons, including the law and the realities of the majority of such conditions. Inpatient care is typically term limited, especially substance use disorder treatments. Common inpatient terms are 6 weeks to 2 months, 90 days, a year, 2 years. The longer categories here, a year, 2 years, often divide the time between strict inpatient congregate living and then some portion of time in transitional housing. And transitional housing normally resembles real world living with some differences. It is often living alone, but typically involves at least one roommate, sometimes multiple roommates. Transitional housing often has a program employee on site who make regular, perhaps daily or multiple daily visits to the site. And some facilities have less frequent visitation, such as the case with high functioning individuals suffering from a severe or persistent mental illness that is currently being well managed. In severe cases of mental illness, inpatient or residential psychiatric living may go on indefinitely. Each of these areas, again, just like our original site, may be a way station to different points of care. Patients frequently move voluntarily or involuntarily between various levels of, for example, substance use disorder and the criminal justice system. Or they move from crisis or acute care to outpatient or to inpatient care. While the specific processes involved in continuity of care will differ in their particulars, in their broad strokes, they should look pretty similar. Their first shared characteristic is that they should exist. Nicotine dependence, like all drug use disorders, requires a long-term recovery effort, and lapses are fairly common. We want to make sure that wherever the client goes next, some support is available to them. And I know some support can sound really vague, but that's because which supports and how many of them are going to be used needs to be determined by the patient at the time they're transitioning. At the very least, we want to make sure that the next care provider knows to follow up on the patient's abstinence plan. Or if the patient is transferring home, then we want the patient to know where they can go to get such follow-up or continuing care. Depending on the patient's current nicotine consumption patterns at the time of transition, we want to make sure the patient has access to cessation medications, ideally, or that is to say, ideally not just access, but possession. Like we want them to have the medication if that's possible. In some cases, especially if someone is leaving a long-term facility where they may have been fully abstinent from nicotine for a month or longer, they may not need at that moment NRT. However, we would want to make sure that the client knows where and from whom they may get medications. And one example of this is those re-entering from incarceration are normally assessed for eligibility to Medicaid. At that time, we would want them to know that they have a cessation benefit, what that benefit is, what choices they have within that benefit, and how to activate that benefit should they decide they need it. And I've been talking so far about continuity of care in terms of follow-up care after service, but it's also the case that there should be a protocol in place for referring the patient to other care providers, setting up expectations of tobacco, especially tobacco cessation related expectations about those providers with the client, and also communicating to those service providers what the client's needs are regarding tobacco cessation or abstinence maintenance. And just as there should be a process for sending patients to other care providers, we would want each provider to establish a process for receiving or bringing clients in from other care providers. And I've already mentioned one such process in the case of acute mental health care, providing a protocol for smokers being brought into a stabilization unit from a mobile response unit. Another example might be imagine a residential substance abuse facility with a tobacco-free policy. And when they get a new resident, they assess in that resident the need for acute detox. And then if they determine that person does in fact need a detoxification effort, they will then send that future resident to a specific external partner site that performs those services. Now, knowing that their own facility is smoke-free, they may encourage the detox site to also become smoke-free, or at the least, to begin the process of transitioning their shared patient toward a nicotine-free life that they're about to experience when they come in for their residency. This would mean starting a pharmacotherapy regimen that the residential facility will be in charge of finishing with the client. In this case, the detox facility may do the assessment and treatment planning, and then communicate to the residential facility the patient's progress and prognosis. Or it could be the case that the treatment facility does that initial assessment at the same time as they assess for the need for detox. And knowing that they will then become the main facilitator of the tobacco cessation plan, they may do the treatment planning and then ask that the detox facility maintain that plan on their behalf while the patient is in the detox facility's care. I know, I know that all of this is a lot. I know that it's still complicated. As I said at the beginning, the behavioral health system is what it is. A model can only impose so much order, but I hope that our main organizing principles provide some clarity of what our collaborative space looks like, and I hope I provided some examples that clarified some of the more difficult terrain. So I'm going to go ahead and end there and turn the mic back over to Derek, who will summarize what I said and take us forward to what's happening next.
Thank you very much, Jim, for that great look at the model, its functionality, its structure, all the other considerations that you covered. Much appreciated. And yes, this the model, the system, it is all a bear, and this is our step towards better understanding it and helping agencies to take advantage of what's available to them. So in the few minutes that we have remaining, I just want to provide a really high-level recap of what we discussed, to try to take a step back in a very high-level view of the model. And then again, we'll have a couple minutes if there are any questions at the end. So again, just to summarize what Jim has discussed, I wanted to lay these different categories out so that you can see them all in a very simplified manner, if you will. So again, just to reiterate, category 0 services are not explicitly part of the Colorado behavioral health system, but nevertheless, they are important components that we want people to consider within that context and within our model. So again, these include community-based prevention services, so standards such as nicotine-free policies and other supportive organizational policies, early identification and intervention, so your typical screening and referral functions such as the 5As and other standardized practices for accounting for each patient encounter. Health promotion, so education and promoting these sort of policies and procedures in schools, jails, primary care settings, and all different types of community organizations. We then have our models category 1 services, which are the mobile crisis response here. So a response that's able to reach people in the communities. So meeting people where they're at with tobacco treatment services, as well as referrals. So really that mobile in the community option. The category 2 services, we have our on-site crisis services. So walk-in services, diversion services, in which we might route people to behavioral health care and away from perhaps a criminal justice setting. This might also include co-responder services, working with law enforcement to de-escalate situations, a crisis stabilization unit for people, short-term care for people who might be risk at hospitalization, also our recovery services to help people help reinforce and support recovery, try to really lock in those gains that might be made during treatment and abstinence from tobacco and other substances. Moving forward, we have our category 3 services, so our outpatient and ambulatory services, which may include individual tobacco treatment counseling, perhaps offered by a certified tobacco treatment specialist, group counseling for tobacco cessation, as well as medication, including our 7 FDA-approved tobacco cessation medications and medication-assisted treatment. Also transition services. So these are things that may support individuals who are transitioning from a mental health or substance use disorder treatment facility back into the community. So sort of those transitory services. And finally, our category 4 services, acute care, so short-term acute psychiatric care, but not necessarily inpatient hospitalization, things like mental health and substance use disorder, inpatient care, co-occurring addictions treatment, acute care treatment units, and also intensive care, so substance use disorder services, assertive community treatment for serious and persistent mental illness, and case management offered by perhaps a trained case manager helping an individual in a recovery. So just a very high level overview of the different categories of services there. And to wrap things up for this webinar and to look forward at what we intend to accomplish in the next few weeks here, the final webinar in the spring series, again, will be offered on Tuesday, June 7th at 10 a.m. In this webinar, we will offer several different case studies for consideration, and we'll use the behavioral health cessation coordination model and walk through these case studies in order to try to better understand the model and to demonstrate its utility. So some of the case studies that we intend to look at include a crisis center encounter, a new employee orientation situation, community behavioral health example, and a drug court interactions example as well. So more to come on that, but again, we will be offering that webinar on June 7th. Okay, and as promised, we do have some time for questions. I do want to mention that as everyone has registered for this webinar, we will be releasing the behavioral health cessation coordination model itself in the near future. And as we have your contact information, we can provide those who are interested with that model. And again, it will be available for free download for the public use on our website, bhwellness.org, at our whole health innovation page on that website. And yet again, all these webinars will be archived on our Behavioral Health and Wellness Program YouTube channel. Okay, and with that, we have about 5 minutes left, and I'd like to see if there are any questions from the audience today. So we welcome those of you who may have questions to either enter them in the chat box, or you can also chime in on audio, however you see fit. just give it a little more time in case there's any questions. We do hope that our third webinar in this series will help to further demonstrate the utility of the model, again, using those case studies. We think that will be a fun session in order to actually walk through and see how we can put this into practice.
Yeah, that's definitely true. And, you know, I know this is still, for those of you who are not already like deeply aware of or knowledgeable about the behavioral health system, I know that can still seem pretty overbearing or intimidating. So, you know, if you're still left with confusion about how you would engage in tobacco cessation in these spaces, let us know either here or through email, because we can definitely try to clarify. We can ask clarifying comments in that third webinar as part of those case studies. I mean, I hope that the case studies do that anyway, but you know, if there are specific concerns or questions that you have, then definitely let us know what those are.
And here is a way that you can contact us should you want to follow up on that. We're, of course, available by phone or email. And there again at the bottom is our organizational website, bhwellness.org. One final call if there are any questions. Okay, well, seeing no questions coming through at this time, we want to thank you all for attending today's webinar. We hope to see you in the future, perhaps our June 7th webinar. And we hope that this model will be useful to agencies across Colorado. Okay, thank you very much.